Welcome back to the implementation track. I'm Dr. Damon Durker, Director of Optometric Services at Eye Surgeons of Indiana in Indianapolis. I will be with you all weekend on this track. Part of the obstruction was just a fantastic opening session. We'll get right into our next session. We know that dry eye, MGD really is the leading cause of dry eye. And in order for us to properly treat somebody that has Meibomian gland disease, we do have to clear their Meibomian gland obstruction. And there's a tendency for us to, it's a complex disease, multifactorial, but do we sometimes make it a little bit too complex? And that's really the topic for this session, the MGD myth, which is brought to you by TearCare. TearCare is one of the newest technologies in the dry eye space to help remove Meibomian gland obstruction in the office. And I'd like to welcome my colleagues, Dr. Marc Bloomenstein and Dr. Derek Cunningham, to lead this session. I'll be in the chat and I'll be back at the end for live Q&A. Gentlemen, take it away.
Thanks, Damon. I'm Dr. Marc Bloomenstein from Scottsdale, Arizona.
And I'm Derek Cunningham from Austin, Texas.
Derek and I are really excited to be able to be here at Eyes on Dry Eye, talking to you about what I think people think is probably a complex and just multifactorial dry eye, just complexities. And I think what we're going to try to do is break down some of those myths.
It's going to be fun to shed some light on ways that we have made dry eye more efficient and really simplified it for not only ourselves, but our colleagues and our clinic staff as well.
Yeah, it's funny because we hear a lot about, I don't have time, or this is something that I don't have the tools to do in our practice. And I think Derek and I will both be the first to tell you that, yeah, you do. You've got the tools, you've got the time, and hopefully we'll make it easy for you to be able to go into your clinics, I don't know, when you're done here, I don't know if you're sitting at home or if you're in your clinic pretending that you're working, but you're actually listening to some CE and can go right in the lane and start treating these conditions. When we think about dry eye, I always kind of think of the word dry in itself. Just the word itself can conjure up all kinds of emotions for us and for our patients. And I think for us, it kind of puts us in a position where we think this is something challenging and hard for us to be able to treat. When we think about dry eye as a chronic condition, causing about $3.84 billion burden to the US healthcare system, our patients kind of are affected by it as well. Frequent visits to the office, they have home remedies they have to do. We don't know if we should start them on tears, put them on warm compresses. It becomes a little daunting. And more importantly for us as doctors, it just becomes kind of unsatisfactory. We start patients on treatments. We don't get the results that they think they're supposed to get. Or we wait for symptoms and we ignore the signs, or we see the signs and we ignore the symptoms. We want to prepare them for their contact lenses, or we want to prepare them for glasses, or better yet, for surgery. And we see that 1/3 of the visits of patients with dry eye or dry eye-related symptoms are coming into our practice. And I almost kind of feel like it just becomes a burden on the whole system. What we've realized over the last, I would probably say 10 years, give or take, is that Meibomian gland dysfunction is probably one of the biggest burdens that we have. Let's use that word burden. It's attributed to about 86% of the total dry eye disease cases. And what we're hoping to do is to be able to kind of remove some of these myths around this condition, or better yet, make it easier, make it more practical for you to be able to manage these patients, especially in and around Meibomian gland dysfunction, and as it really relates to dry eye disease. When we think about Meibomian gland dysfunction, one of the realities here is you see a tear film that is kind of just doesn't look great. Just look at the sad face there, super sad. You see Meibomian glands that are obstructed. We see the tears are evaporating. We don't get that good, healthy ocular surface, which the cornea needs, the epithelial tissue needs, but more importantly, the refractive clarity is not going to be there through a tear film that looks like this. And we think about the impact of Meibomian gland dysfunction. Low production of the meibum means evaporation of the tears quicker, the disruption of the tear film, which then in turn creates this loss of homeostasis, which in turn creates more inflammation. Hence, our patients can't wear their contacts as comfortably. Their vision fluctuates. And more importantly, we see corneal damage and eventually poor refractive or cataract outcomes. Meibomian gland health really is integral to all of the things we do as optometrists, but more importantly, it's so important for the things that our patients want to do, especially when you think about screen time, like you're doing right now. Think about that. Blink a few times for me. Yeah, you're secreting some Meibom, or are you? So Derek and I are basically going to be myth busters. Oh yeah, we're going to uncover some of the truth behind these popular myths about dry eye. And again, I've already shared with you that I think just the term dry eye is a myth in itself. I mean, it's like, Derek, if I say dry, what does that make you think of?
Again, it means you think of tissue that's just unresponsive, doesn't work anymore, and where do you start kind of idea.
Yeah, I just think, to me, it's like patients just think, oh, it feels dry, or it's a feeling. It's more than a feeling, doctors. It's something that's important for that refractive surface. And so when we think about this myth that dry eye disease is complex and it's difficult to treat, this, to me, I think is the #1 myth that has to be broken down. Because let's be honest, right? You see all of these articles that come out, all these headlines about complex and multifactorial. And then you start to see all these algorithms that come out where it's like, start here, move here. If that doesn't work, do this. That's just not practical. And more importantly, when we start thinking about some of the important research that's done, and not to take anything away from the do's or the do, which they did in Paris, the reality is that none of us either have time to read this, or the challenge is implementing this in our practice, which then in turn, I think causes us to step back and say, you know what? I don't either have the time, nor do I have the tools to be able to do this. That first myth about this being something super complex and super challenging for us to be able to manage in the lane really is the one we need to break down. When we start thinking about all the many different possible contributors to dry eye, one of the first things that I think about is I think about how my kids, what their life is going to be like in 10 or 20 years, and they're in their 20s. They're on a screen, an iPhone, they're on a computer. I asked my son the other day about something on NBC. He goes, what's NBC? I go, you don't know what NBC is? He goes, is that Hulu? Is that, I'm like, dude, no, it's a television. He goes, I don't watch TV. I just watch it on my computer. We see all of these different challenges to our eyes. The truth of the matter is that we're not going to be able to manage every single one of them. And yet, one of the things that we know to be true is that when the Meibomian glands are affected, we can have obstruction of those glands, which in turn can also create and does have inflammation. We have both inflammatory issues as well as obstruction issues. And I think if we break it down quite simple to managing inflammation and obstruction, then I think we can kind of break down this myth. This is basically treating inflammation and obstruction, the two key offenders, when we start thinking about especially Meibomian gland disease and especially how it relates to dry eye.
The next myth we're going to tackle is the idea that advanced formulation artificial tears can reestablish homeostasis. And the genesis to this idea, I think, comes from our history in eye care, in that we had limited resources, probably a more limited understanding of where dry eye came from. Marc already covered it. There has been really extensive looks at where dry eye comes from, and it can be very complex and very difficult to understand. But the same idea holds true no matter what the cause is. There's a pathophysiological problem in the structure of the eye itself, whether it be a specific component, whether it be mechanical. And the idea that simply flushing more fluid into a system was going to fix a cellular response or a poor cellular mechanism is just not going to happen. So let's look at this myth a little bit closer and why we maybe think we have to alter our understanding of what tears do and what their place is in dry eye. Remember that the dry eye idea initially came to the forefront in eye care probably 40, 50 years ago, and the idea that if we could simply just add more lubrication, we would be able to stabilize an eye that didn't have enough. As we've evolved our understanding of dry eye, we know now that we have separate layers in the tear film, and it's not necessarily the deficiency of any one layer, it's the recipe of the 3 layers together and how much you need of each one. So if you're deficient in one, simply adding a whole bunch of the other won't necessarily stabilize the tear film, and it can actually have a negative effect. For instance, Marc has been talking a lot about Meibomian gland disease, and we know that's a leading cause of dry eye. Well, Meibomian glands produce lipid. If we're not having enough lipid, can we just flood the system with more lipid? Well, that actually hasn't been the case. What we've actually found with a lot of these lipid-based tears is they simply add a lot more lipid to the surface, but they are not incorporated into your tear film itself. They don't give the structural function that we need. Secondarily, we have a lot of patients out there that may feel like they need to use artificial tears, or you may advocate artificial tears dozens of times a day. The problem with that is you do have some good components to your tears, like lactoferrin and pro-growth hormones, that you could be inadvertently flushing out or getting rid of the last little part of your good tear by excessively using an aqueous-based tear. So the goal is not to really go in with artificial tears and fix the problem. Our new understanding of artificial tears more relays into, let's get the glands working that are supposed to produce the right components, and then the artificial tears can be a subsequent therapy or a barrier function that temporarily helps the eye. We know that artificial tears lack the biological activity of your natural tear. Your natural tear is simply filtered blood. It's the serum really from the blood, and they're almost identical in nature and composition. There's no tear that can mimic those biological products, but if you could reestablish cell function and produce a more natural tear, I think that's the first building block in reestablishing a healthy eye. The tears can be very beneficial in providing a protective relief, but they have a limited function in the eye and a limited time that they will be available. And the last thing is, when it comes to the lipids or other key components within the tear, although our artificial products can provide momentary relief, they really have a difficult time incorporating into the structure or even providing the biological effect that the natural gland would if it was producing its constituent as needed. So in this case, tears are still a very valuable aspect of dry eye, but we don't use them as a primary therapy. They are a subsequent therapy to whatever step we're taking to reestablish normal cell function. The next myth is going to cover topical anti-inflammatory pharmaceuticals and the traditional myth that they can fix Meibomian gland disease. When it comes to current medications and management of inflammation, we know how critical anti-inflammatories are, and they're a hallmark of treatment not only in eye care but throughout medicine. And in our clinics, it's really no different. They play a critical role in reestablishing temporary homeostasis, but you have to be more understanding of where their limitations are. In Texas, we all love steroids and we use a lot of them, but we understand where they start and where they end. And the end is really to get a more manageable tissue or a more manageable organ to deal with, and that's really why we're using it. Without stopping the inflammation cascade that some of these products can do, any subsequent treatment is doomed for failure often, and so steroids are a first-line therapy often to just get us to a better place, so then our subsequent therapies have a better chance of working. If we look at an inflamed eye like this, you can understand when you look at the anatomy and the architecture, by simply calming down the inflammation, the patient will actually get symptomatic relief, and that can be very effective at initial therapy. But unfortunately, the anti-inflammatory will do very little to unobstruct the gland. And that's critical to what we're talking about in establishing long-term health of the eye. Again, you can steroid people and you can steroid them over and over again and have them feel a lot better. But what we really want to do is find a way to use the steroid to help other therapies work more efficient and better, and ultimately get patients self-sufficient without the use of medications. So the concept historically that we looked at with anti-inflammatory therapies and how they work still holds true, but you have to understand where we're going to put them into play and how we're going to use them to make our other therapies a lot more beneficial. We look at these prescriptions historically, they can be expensive. We also know that strict compliance is necessary for them to be effective. So that has a finite time that you can have someone use this. They're not going to use it forever. Number two, they're not going to pay for it forever. But also number three, we have clinical side effects of steroids we're well aware of. In the short term, they're not a big deal, but in the long term, they can be. So in a clinic like ours, or in my setting, I rely heavily on steroids to establish a calmer environment. And that allows me to be far more effective and far more efficient when I choose something like a tear clearance device to be used. So in this case, the myth that the steroid itself is going to reestablish normal cell function within a blocked or occluded Meibomian gland is just not going to happen. It will control symptoms, and then from there we can move on to more efficient ways of clearing the Meibomian gland and truly helping long-term dry eye in these patients. And with these challenges we have in anti-inflammatory drugs, they're really multifactorial and they're multi-steps. I think we can all convince our patients to use a short-term steroid, even though they may have to go through a special coupon or a PA. But if you consider immunomodulatory drugs as anti-inflammatories, certainly the challenges to us and our staff to get these approved for a lot of patients can be very significant. Again, none of these theories, or basically none of these treatment modalities, I really feel are competitive. A lot of them are synergistic, but when you have to pick and choose what's going to be most beneficial, and also you have to run a busy clinic, clinically, we tend to go for a steroid first, just to allow our other therapies to work a little bit better. We then try to reestablish more normal cell function, and then from there, again, we can reassess the need for a long-term immunomodulator and see if it's really worth the fight with our staff and clinical challenges to do PAs and things of that nature. We also then, with medications, have to understand compliance and the compliance issues, and really how long can you get a patient to be compliant with any certain therapy. Whereas if you're reestablishing cell function, you really have a chance for the body to take over and compliance to be a minimal issue. Ultimately, we know that some of these drugs will also carry side effects. And again, I really am an advocate of using short-term steroids because of how effective they are, but certainly we don't want to stretch that out too far with the known clinical side effects in this case. So again, I think we see in this case that the myth is certainly somewhat upheld in that you have to have a synergistic approach of decreasing inflammation to have a better chance at evacuating and maybe maintaining sufficient glands. But overall, it's busted in that the steroid or the immunomodulator is gonna do little to nothing to unobstruct the gland physically and then reestablish normal function within the gland itself. With this myth, we're looking at the idea that obstruction is too difficult to treat. The genesis of this one, I think, holds true for all clinicians in that none of us were ever educated in school on the idea of treating obstructions. We're eye doctors, this is not germane to what we do. But if we look at our medicine colleagues and across all aspects of medicine, we see that if you do not treat obstruction actively or intervene in the obstruction of whatever lumen or vessel we have in the rest of the body, it simply is not going to fix itself. And we're understanding the similarities between the eye, especially the eyelid, and the rest of the body. Remember, as our evolution of dry eye understanding proceeds, we're realizing it has a lot to do with the rest of the body and much more than we have historically been comfortable with in dealing with properties within the eye itself, which is somewhat of an isolated system. And think about coronary artery disease. You could certainly treat this to a certain level until you have a significant amount of blockage, but at that point, you actually have to intervene because there is no statin that's going to help an artery that is almost entirely included. And then we have the idea of warm compresses, and historically where we failed. I think we've all tried this, and certainly our colleagues have tried the idea of using warm compresses for decades with limited effect. And some of Blackie's study data really shed a lot of important light on this. You really need to have an internal heat within the gland of a specific amount of time. And if you don't reach that temperature for a specific amount of time, you are not going to adequately heat the meibum. And in order to do that, not only do you have to have that temperature inside the eyelid, but any contact you have with the external eyelid will typically have a limited effect because the vasculature in your eyelid is going to take a lot of that heat away. Secondarily, whatever heat you put on will lose its energy relatively quickly, almost exponentially, and you'll have a limited effect, maybe even only up a couple minutes of effectivity in a typical warm compress. So it's very hard to maintain that therapeutic temperature within the gland itself. And ideally, if you wanted this to have any clinical effect, as Blackie saw, you'd have to do this several times a day. Now, don't forget that we're dealing with an inflammatory disease in its genesis and to start with. So also the very directed heat and lack of collateral damage of heat is super important. To me, I don't want heat on the lid margin because that's where you have very thin skin and a lot of telangiectasia or superficial vasculature. Where I need all my heat to go is right to the lumen of the Meibomian gland itself. So when we look at obstruction of the glands and how we can view this, there's a couple other aspects we have to look at as well. The gland itself is not going to get cleared by itself, regardless of what steroid or traditional therapy we use. On top of that, any significant length of inflammation will cause a keratinization over the orifice of the plaque. or over the orifice of the gland. And these are these little plaques. Now, you can't see them under the slit lamp. They're invisible, they're clear. But if you take a little removal device, you'll actually be surprised at the almost fish scale nature of the lid margin when you go and remove these things. And unless you remove these plaques, you have no chance of actually evacuating the contents of the gland. And I think that was historically a big issue with a lot of us that started doing this, and we thought it was difficult because we were having limited success in evacuating these glands. And in order to get to the inflamed tissue itself, I think the first step is always to get the contents of the gland evacuated, allow it to reestablish normal cell function, and then control the inflammation long term. That's typically the plan. So in this idea of obstruction is too difficult to treat, I touched on some of the historical issues that we had in treating glands. Let's look at some of the innovation that's been developed to allow us to do this more effectively. And that brings us to the TearCare system. We're going to dive into some specifics on what sold us into TearCare. Marc, in your case, what was the genesis for you finding the utility in your clinic with this?
So, great question. I mean, we actually were involved in one of the clinical trials, and I actually had the opportunity to compare the TearCare system to the LipiFlow system. And the first thing that you noticed right off the bat is just the absolute, just kind of almost the beauty of this device. This handheld device, the kind of simplicity, if you will, of the smart lids. And the challenge that I had, especially with the LipiFlow system, was that it was bulky, self-contained. We couldn't move it from lane to lane. We have 3 offices in the Valley, and the notion of having people drive in, I don't want to do that. So having something portable was something that really appealed to me and appealed to our practice. The second thing was the anxiety I think patients have of sitting there for 10, 15, 20 minutes, their eyes are closed, taping the activators on the LipiFlow system, they would fall out. And so it's little things like that that made you step back. But the bigger thing is that I kind of felt like it was a black box. We didn't know what we were doing. We couldn't see the Meibom that was coming out. What's beautiful about the TearCare system is that patients are sitting in a chair, they're reading their phones, they're blinking, but then I sit in behind the slit lamp and I can actually physically watch the Meibom coming out of the glands. And I think there's an absolute psychological benefit to letting patients know, I can see what we're producing. I can see that we're reaping the benefits of what you just did, and I think patients really appreciate that. So I love the fact that it's portable, and I also love the fact that it's kind of like an open room, and patients really like that.
It's interesting you bring up simplicity. That was really one of the things that really initially I was quite dismissive of this technology because of it, because we had these really elaborate, heavy systems, and when I first saw this system, I was struggling to understand how and where it would be better. And it's funny, we have incredible similarities in how we like the device once we've started to use it for a while. When you're doing this, you have some control, you know what's going on because you can actually witness this. And I guess I alluded to that a little bit in my medications. It seemed to make my medications work a little bit better, but I'm not always there to make sure they're taking the medications. In your ability to be more controlling of the results of this, how does that play into your clinic and what you do and how you approach dry eye now?
Yeah, I mean, I think one of the biggest challenges we have as clinicians is we set a patient on a path and then we expect them to actually do it. And the harsh reality is that they don't. Or maybe they say they're doing it, but they're not doing it accurately. What's great about doing something like the TearCare system, but what I like is that I actually know that I'm getting something done. I actually know that if there's a gland that's obstructed, that I'm actually going to keep removing the Meibom that's being removed from there. And more importantly, I know that the patient's actually going to be getting benefits from that because I physically can see it and I'm actually doing it.
To me, the value of this indication or this FDA indication that you see here is that it's actually an indication treating the root cause of the problem as opposed to traditional medical therapies or even artificial tears who are just trying to address the symptoms. So a robust indication here in conjunction with clearance of the glands, I think is important to understand what you're trying to do with a procedure like this. And if you get your hands on these things and you get to use them, you really realize how simple they are to use. They fit almost every single patient that you're going to get in your clinic. it's very consistent and precise. It's controlled and regulated through the entire treatment itself. It's a very pleasant treatment. It also allows for me something very important. You know, the Meibomian gland itself is an accordion type gland that has muscles that squeeze meibum out upon blink. So a lot of my patients think it's almost like a spa treatment, and that's really kind of how they'll view it as well. And then we have what Marc talked about earlier. We have this portability. I'm Canadian, I love hockey. This is a nice little hockey puck for us, so we like this in our clinic a lot. It also has an intelligence to how it's going to control the heat. If there is a break in the applicator and it's not against the skin the right way, the hub will let you know. It's going to monitor its temperature the whole way through. There's a lot of things I like about this device, and it kind of endeared me towards this treatment. What do you think?
No, I love it. I mean, the great thing about this is it makes me a better doctor. And the main reason why is exactly what you said. I mean, 240 times per second, it's checking to make sure that those temperature is where it's supposed to be. If it doesn't, there's an alarm that sounds. I know exactly which eyelid is actually being affected. Moreover, if you look at the Smart Hub there, you can see exactly the temperature you're at, because when it first starts, it kicks in really quick. You said about being a spa day, and whoa, I feel it, but then gently, it's like 2 degrees every, I think 20 or 30 seconds, it increases until it gets to that optimal temperature. And then you also see exactly how much time's left. So, the Smart Hub really, honestly, I think it makes me smarter. I really do. We talked before about, getting in there on the glands. We use these clearance assist forceps, if you will. But you can see from the picture, and this is something that I feel is maybe lost a little bit. In school, we didn't really learn how to do these things, but once you get your hands on it and you start doing it, it's really, the simplicity of it is what makes it nice. Because you literally can get from the base of the gland, and you were talking before about not wanting to be at the orifice. I like to get at the base of the gland, and I'll come up. I actually will sometimes turn my forceps and make them vertical to get a little bit more of just kind of a more narrowing of the gland. And so it's that real-time patient feedback. And I mean, do you ever look and just go, oh, I'm getting so much good stuff out of here?
Yeah, we do record some patients and that want to see it. The second thing I think that Marc touched upon is something that I wish I had right at the beginning of learning to use this. There's a lot of experience that you learn from clearing these glands, and it's something that initially seems daunting, especially for, like I said, an eye doctor who is not comfortable, who doesn't really want to touch their patients, especially not manipulate the lids like this. And then you learn, like Marc said, if you address the gland from the bottom up, so you're not pushing the meibum back down, if you realize that people with more inflamed eyelids or more advanced disease are going to have a thick rolled edge, and you want to stay away from that, or else it's going to snap and be very uncomfortable when the forceps slide off. And the last thing, that we've learned from a lot of Don Korb, the godfather of Meibomian gland disease, is it's not necessarily how hard you're pressing, it's really just how long you're letting the compression happen. So I think a lot of things that also we made mistakes on early on was we were compressing too quickly and just moving on to the next section of the glands. Whereas if we give this a compression and hold it for about 5 seconds, you'll be amazed at how much content will come out after 3, 4, even 5 seconds when it starts to come out. So those are all lessons that we've learned that really helped us be a little bit more efficient in this. And as soon as the Smart Hub is ready and the alarm sounds, that's when it's very effective to get in as soon as you can to clear this. And it gives the patient a lot of face time with the doctor at the end, which they value a lot. Marc, we both do a lot of studies, but what's really impressed me about a relatively recent device like this is the acumen of research they've had able to compile in simply the last several years. You were actually part of some of this research. Can you tell us a little bit more about it?
Yeah, I mean, it is exciting that you can be able to go back and look at some evidence-based examples of therapeutic improvement. You can see just by looking here at the slide, you see cornea, optometry, and vision science. That was a investigator-initiated study that Tom Chester did, where he had 92 patients, for example. And when you looked at the Meibomian gland secretion score, which Derek, you had mentioned earlier, looking at the gland and actually seeing a gland that really wasn't working well, and now it's working well, he had 87 out of 88. And we started thinking about, are patients actually feeling better? Are they getting a little bit more symptomatic, or less symptomatic, I should say? And especially in his, you see that there was a huge improvement. whether it be the clinical ophthalmology studies that we've seen across the board here, there's been a lot of different studies. Now, what's exciting for me is that I was part of the Olympia study. And this is one of the most studied devices in meibomian gland dysfunction. You see the Badawi studies 1 and 2. We saw Tom's study, the Cheetah study. We were part of the Olympia study, and that's where, I gotta be honest with you, I really saw this significant improvement. This was a single device. It was whether it was used the LipiFlow versus the tear care. And we looked at tear breakup time, we looked at corneal staining, we looked at OSDI. So we saw a really significant amount of different areas that this has been studied in, whether it be staining or whether it also be meibomian gland secretion scores. So you should, and I encourage anybody who's listening here, go read some of these studies. You can pick up your phone and you can actually use this QR code right now, and it'll take you to a site where you can scan each one of these peer-reviewed publications. And don't take it from me or take it from Derek. You can look at these evidence-based studies and go straight to those peer-reviewed publications to see how well this is performed. So we've talked a lot about our experience and when we first got our hands on this device and maybe even the skepticism we had. But the reality is that once you actually see it, once you actually can touch it, it makes a huge difference. So I would encourage you, not now because we're not done, but when you get a second, go to the virtual exhibit hall and get a rep to come into your practice. Request a demo. Do it in your practice. I mean, do you not agree that hands-on?
Yeah, it's interesting. You mentioned you were directed into this from a study. In our case, it was the same thing. There is some skepticism with any new paradigm shift that involved. And this not only changed the way that we treat dry eye, it significantly affected the way we used other devices in our clinic. And so I think the idea of getting your hands on this will significantly change, for the better or worse, your understanding of meibomian gland disease and what you want to do in the future with how you manage dry eye.
Yeah, I think it sets a high bar. I mean, it really does for other devices that you have in your practice because of all the attributes that we've already been talking about for the last 30, 40 minutes. So, we think about this, obstruction is too difficult to treat, busted. I mean, both of us can contest that it is quite simple, and more importantly, we have a better way we can do it. And I think that better way for both of us is the tear care system. Proven. Proven?
Proven.
Proven.
Great session, gentlemen. Mythbusters here live and in person. Marc Bloomenstein, Derek Cunningham. Well done. We've got quite a few questions here about the tear care system. Was that a fun session to do?
Yeah, it was a lot of fun. Derek, you couldn't see, but Derek's hand just kept creeping under my chair the whole time. So, yeah.
Very good editors over at the Sci Sciences. Well done.
I felt violated.
All right, we'll get right into it. So we had a question about microwavable heat masks, and is that warm enough to do a manual expression? What are you guys' thoughts on that?
That's an interesting question. That's go ahead.
What I was going to say is I think those are good for like a kind of a maintenance, a home remedy. The problem is that the temperature really starts decreasing pretty quickly. And I don't think that you get that sustained heat, enough of the sustained heat to do a manual expression. It's not completely well controlled like you would get with the tear care system. Derek, what were you going to say?
Well, my issue is it really comes down to it. Any passive heat device, I'm not sure how much heat is actually going to get to the glands themselves. And surely, we've seen a fair bit of data, mostly by Don Korb and Blackie, that really show that most warm compresses don't actually transmit the heat actually to the gland itself. They simply just heat up the external eyelid, and then the blood vessels in your eyelid just take all that heat away before it actually gets to the gland. So because of the variability issues, like Marc said, and also because probably there's a lack of the amount of heat that's getting into the lumen of the gland itself, I'm really not a fan of any kind of the home remedy heat masks. We just haven't seen any effect from them, to be honest with you.
Great. Big points of the discussion, we're trying to make it simple, right? Inflammation and obstruction. So we had a question come in about steroids, and we talked about that, and you said, boy, Texas, we love your steroids, and I assume you mean topical steroids for dry eye MGD. But what is your steroid of choice and length of steroid duration, Dr. Cunningham?
You know, it's interesting. I guess we have a template, but it's really patient and patient specific. With the loteprednol-based molecules, I feel totally fine using those for at least a month, to be honest with you. And again, I like to steroid someone beforehand. We learned these from a lot of our blepharitis trials, that the less inflammation they have coming in, the better gland expression you will get during your time there. And then the last thing is, no matter what we do or what device we use to express glands, you are creating an inflammatory cascade because of simply the mechanical forces that you're doing. And the heat itself is also going to increase inflammation. So, you know, for those two reasons, we also like to at least use a steroid for a couple of weeks after every treatment. And that's across the board, to be honest with you. But in a perfect world, yeah, we pre-treat with a steroid, and again, we post-treat. Now, a lot of the post-treatment is just to make them feel good until they can feel the benefits of the gland expression, to be honest with you. But the pre-treatment is necessary to get a good treatment, in my experience. Mark, what do you think?
Yeah, I agree with everything Derek just said. And if I come in and out, I apologize. But I will also say that, you know, using like an immunomodulating agent, or, you know, some of the more chronic long-term dry medications that we have, I think that can help to kind of control the inflammation. So, you know, I think a question that arises often is, how often do you need to do like a tear care procedure? You know, is it something, and I gauge it basically by how the patient feels, how they're doing. You know, it could be 3 months, it could be 6 months. For some patients, it could be a year. I mean, I try to get the patient to basically say to me, oh, I think it's time, or, you know, I could look at them and say, you know, I think your glands need this. But the whole time they're utilizing, you know, whether it be, you know, a low dose loteprednol, like Derek said, as a rescue drop, you know, for that kind of episodic dry eye, or they're maintained on an immunomodulating agent, whether it be lifitegrast or cyclosporin.
It sounds like you're both using loteprednol for short durations around the time of their tear care procedure to help with the inflammatory component. Do you use that at a PRN sort of dosage as well for dry eye flares, or do you do something else?
Well, you know, in a world, we're all in the real world, right? So I do use loteprednol very aggressively around treatments, and then I do use it judicially for flare-ups down the road. Now, being that we're in a real world, there's also, I think, an excellent alternative to loteprednol, and that's Flarex. And I want to be clear, because this always gets messed up. Flarex is not FML. So if you're using FML, in my opinion, it's completely useless for ocular surface disease. It does nothing. There's a difference between an ester and an alcohol. And basically, Flarex, for the people who can't get loteprednol covered under insurance, is an excellent alternative. And we end up using that for a lot of our Medicare patients, simply because they can get Flarex a little bit cheaper. And it's a good second choice. And again, almost on par, I guess, in many cases. But loteprednol seems to be the one we go to the most, with the most experience, that kind of idea. And that's kind of where we'll put it. Now, to be honest with you, any steroid will work, but we've got to remember, the stronger the steroid, the more significant the side effect profile. And that's not just IOP. You know, one of the key, let's say Durezol, which was been my favorite for around surgery for years and years and years. One of the key side effects of Durezol is SPK. And a lot of people don't realize you can put someone on a steroid and actually make their ocular surface worse. And so you got to be mindful of basically what you're using, how you're using it, and what the common side effects are.
Great. Let's pivot off the steroids and look at maybe just day to day. And we'll start with Mark. In Arizona, your practice, you identify somebody that is a good candidate for tear care. How does that look in terms of your patient flow? Do they see a dry eye counselor? Do they talk to a technician? Do you do start to finish everything for your patient? Do they come back? What does that look like day to day in your practice?
So again, hopefully you guys can still hear me and see me. Let me know if you can't. But in my practice, I try to keep things simple. You know, when they're sitting in the chair, talking to them about options or opportunities, what's great about the tier care system is that it's so tiny that I can roll it into any lane at any given moment. The fact that it takes like 15 minutes, I oftentimes will talk to patients about, look, we can do this right now. If you have about 15, 20 minutes, I think it would be in your best interest. I don't like bringing counselors in. I do the debriding myself. I'll start the system, walk out, check on them a little bit, let them know they can get on their phone or do whatever they want. And then, you know, I'm pretty immediate on the spot there. So I like to try to do it while they're there at that moment. That's my preference.
Derek, what do you think?
The nice thing is we had a chance to template a lot of this years ago. We used to do a lot of LipiFlow. And the tier care for us has been much more directed therapy, and I don't get the collateral heat and damage that I got kind of with the compression from the LipiFlow and the uncontrolled heat. So we're pretty standardized. We have a dry eye clinic, and so people come in for an evaluation, and when they always get booked and a separate appointment to do their lid evacuations with the tier care. The great thing about a clinic that does enough of these, eventually, this doesn't affect the doctor time at all. So I will evaluate them. But then I have certified technicians that will go in, and not only will they be able to clean the eyelid margin for me, which again, this is something that took a lot of training, but they'll clean the eyelid margin for me. They'll apply the applicators. And at least on the first tier care, I do like to do the expression myself, just so I can understand what's going on. I can really grade what's happening, and I can get a solid understanding of what's coming out of the glands, which I can never do with LipiFlow, to be honest with you. And then from there, we go back and I have independent appointments where people come back getting tier cares, and it's all run by staff, and it doesn't affect our doctor time at all. But that's kind of down the road stuff. That's, I think, once you get really comfortable with the technology and you're using it a fair bit, but it's very efficient for our clinic.
So more doctor driven on the front end of that, you get the patient controlled, and then for the maintenance treatments, you tend to delegate that almost entirely to your staff. Is that right?
Yeah, that's exactly right. And our staff is all educated on how to grade Meibomian gland secretions. Every time someone has an expression after tier care, they get graded on how many glands are being expressed, what's the quality of the expression, and this is all compared to subsequent treatments. So we track the data very, very accurate, or very consistently. And it's funny, our tier care patients, very much like our glaucoma patients, will come in and say, hey doc, how many glands this time, and what was the expression content? They get really up to speed on exactly what's going on.
Yeah, that's what I find too in my practice is we educate, we show some videography of their initial slit lamp. We try to do that after we do the expression, and so they can see what's coming out. And then the patients are more engaged, and then they're asking me, what my glands look like today, Dr. Durker, and I can share that. And I have not yet move towards a full delegation of the procedure. I think that's interesting, but certainly I think that's in our futures with just the number of people that need treatment and the number of practitioners that are providing that right now, is we're going to have to use our whole team to be able to do that successfully. That leads us into a question we had here is, how often should somebody receive a tier care treatment? Marc, you want to jump on that? Marc's not with us anymore. There he is.
I'm sorry, Derek. Derek, I didn't hear. No, I couldn't hear the question.
Oh, looking at a question we had was, how often should a patient have a tier care treatment?
Yeah, I think I commented on that last time. I tell patients, look, you know what? When we first start, it could take, it could last for months. We kind of go and evaluate it, kind of like Derek does, just looking at the specific glands, seeing how they're working. I bring them back every 3 months to evaluate it, and I think because it's so titratable, so easily to do. For me, I mean, some patients will go 3 months, 6 months. Other patients may go a year. I've seen so many patients that have improvement in like their OSDI or their speed scores, where I've never seen that before. So it's really kind of, it's a little bit of a patient driven on my side.
Anything different with you, Derek?
Yeah, it's actually the same thing. So initially we looked at all the FDA studies, and we looked at like the stuff that Marc did, and we had these 6 month metrics. But the interesting thing was, it was really a matter of, that was an arbitrary point where they kind of found the data was starting to slip, but you don't have to let the data, you don't have to let their dryness symptoms start to come back before you retreat. So I was surprised when we first started doing this. I had some patients that asked if they could come in and do it every 2 months. And I just kind of scratched my head at the beginning, but then I thought, well, gosh, if it makes them feel really good and they start to get symptomatic return in 2 months, absolutely. And I have other patients that, you know, it does an incredibly good job of, I guess, stabilizing their lipid secretions. And I look at them at 6 months and say, they look great. You know, let's reevaluate in a year. And so it's just really based on how they present when they come back. And I tell every patient this. My goal is to extend the time between your treatments as long as I possibly can. Maybe we'll use hypochlorous acid, or maybe we use this or that, but I don't want to do this nonstop all the time. I want to reestablish normal cellular function and keep it there as long as I possibly can. And then when I need to go back and unobstruct the gland, I will.
Great. Valid question here from David. I'm going to direct this to Derek and then ask Marc to comment, is why is Derek wearing a head covering? Dr. Cunningham, any thoughts on that?
Today's not supposed to be my surgery day, but I ended it for a little while. So,
Marc, do you have any comments on Derek's head covering?
He's chilling. He didn't care anymore.
All right. Question from Courtney. We talked about loteprednol. Do you use Isuvis in your practice, Derek?
I do. And like I said, I love Isuvis as a chronic therapy for flare-ups. I find a lot of value in it. But basically, I do like a little bit of stronger steroid, probably for an acute treatment therapy. And so it's weird. I do find a difference between loteprednol and Isuvis, and I actually find a lot of utility for them both. So I use Isuvis for more as the take-home drop. You use it when needed for flares, and I use kind of more of the Lotemax as I'm acutely treating and I'm going to aggressively, you know, get on things.
Great. I think we may have lost Marc. Final question here is, what are your thoughts? Is there coverage for tear care in Austin at this point, or is this a self-pay procedure?
You know, it's interesting. This is really a treatment that's evolving, and we've participated in a program to help try and get this approved, and for insurance carriers. So we currently do apply for insurance coverage on all of our patients. So we do submit on the patient's behalf. At this point, no, I would say that we haven't gotten anyone covered yet. But this is how all procedures have to start. In order to get any type of surgical coverage, you have to start submitting to insurance and show a need on a consistent basis. So we have several other practices that are also doing this. And their hope is eventually to get insurance coverage. But I can tell you that it's not going to affect the amount of these that we do, because this is one of the very few things that give people immediate relief. And secondarily, it's worth it to people. So right now, when they're paying out of pocket for this procedure, they're wanting to have it done again. And that says everything for a procedure like this. And on top of that, this is one of the very few things. Remember, almost all the medications we use, almost all the drugs that we use, they just treat the symptoms or the end products of inflammation cascade. They don't actually address the problem. And so although steroids are awesome to use to make people feel better, symptomatic relief, you have to move on from that and then really try to establish cellular function. Yeah, I said it before, the big thing for me with all of my patients is to really try to get the eye back to as normal as possible and as healthy as possible. And I don't like drops. So basically, the more I can do to get the patient more self-sufficient and decrease their dependency on this disease, the better. And this has been a huge benefit for our practice.
Good stuff, Derek. Thanks again, Marc and Derek. Fantastic session. The MGD Myth. Go check out Tear Care in the exhibit hall. They've got some great things over there. I look forward to seeing you back in the implementation track in a few minutes to talk with Selena McGee about the technician role in the patient journey in your dry eye practice. Thanks again.
All right. Thanks, guys. Thanks, everyone.